and today we're going to talk about nausea and vomiting in pregnancy. I think we all know this is a very common symptom, and it's the vast majority of women that get this to some degree in their pregnancy. Anyone who's experienced this or knows anyone who has will agree that it can have a really big impact on quality of life. And I guess the big fear, which is often a lot of people's reality, is that it can recur in subsequent pregnancies. Now, hyperemesis gravidarum, I guess it's a term I hear all the time in the emergency department, but I think it's probably overused, and in reality it's less than 1% of pregnancies. Now, there isn't a solid definition that's consistent, but essentially it's severe nausea and vomiting in pregnancy, with either refractory symptoms, 5% weight loss, ketonuria, or significant electrolyte disturbances. And in truth, I think the majority of women we see in the emergency department or in a general practice clinic really just have bad nausea and vomiting and none of these complicating factors. Now, there is such thing as the pregnancy unique quantification of emesis score. I've really just included this for reference for anyone who's interested. It probably doesn't help you identify the cause of vomiting or how to commence treatment. It may well be something you could monitor over time, but my feeling is that any woman or family can tell you how the symptoms are progressing with your treatment. But it's just in there for completeness. Now, before we go diagnosing nausea and vomiting in pregnancy, we just need to think about a few things. Now, first of all, there's some pregnancy factors that can exacerbate nausea and vomiting, and that is multiple gestation and gestational trophoblastic disease. These things, the thought is that may be related to increased amount of beta-HCG released. Urinary tract infections are reasonably common in pregnancy. Gastrointestinal causes such as gastroenteritis or dyspepsia or issues with the liver, gallbladder or pancreas, and particularly the latter few of these are going to be a bit more obvious. Neurological causes can cause vomiting via central means, and also drug-induced causes. Now, having said all this, it's often not that these patients need a detailed amount of investigation, but in general, clinical assessment involving history and exam, a blood sugar level and a urine dipstick is sufficient. Now, I thought we'd discuss some of the brief management principles, and I guess the most important one to emphasise straight off the bat is that the goal of care is improved quality of life at home. So the goal isn't to admit to hospital, the goal isn't to make these women nausea-free, it's just to make them feel a lot better and allow them to function at home. There's a few aspects to this. Now, some principles around diet modification include just trying to eat less more often, because an empty stomach might make the nausea and vomiting worse. Foods that are high in carbohydrate and low in fat might be helpful. Salty, bland and dry foods. Now, when it comes to fluids and antiemetics, it's important that we remember that we have oral, sublingual, intramuscular or intravenous, and even rectal options across multiple classes. And obviously this ends up forming a big component of our management that we prescribe as doctors. Now, in terms of fluid rehydration, oral is best, like with many conditions, and some tips for improving the success of the oral route is to use things that are cold, clear and carbonated, and that might be something like a tonic water or a weakened lemonade. They seem to be well tolerated. And again, like food, small amounts frequently. Intravenous fluid should really be viewed as a rescue option, and it is often prescribed in the emergency department, and that's reasonable, but it should really be reserved for the more severe cases. Got a very simple flow chart here for just starting to think about the management of nausea and vomiting in pregnancy. And really the first discrimination point is can they or can they not tolerate oral medications and fluids? And once the woman can get back to tolerating oral medications and fluids, she can be moved back onto the left arm of this management algorithm. So just quickly, if we have someone who can tolerate oral medications and fluids, really our options are oral pyridoxine or vitamin B6, oral antihistamines that we'll elaborate on, and also the oral preparations of metoclopramide, prochlorperazine, and even ondansetron. And then an oral rehydration solution or some other sensible oral fluid to maintain hydration. Now, if we move to the other side, the women who can't tolerate oral either medications or fluids, there's a few options. Now, ondansetron, as we know, can be used sublingually. And also one that's not commonly used, maybe just due to awareness, is that stemetil or prochlorperazine actually has a rectal formulation, which can be also a very useful option in preventing the need for IV access. Once we've got a woman who really requires intravenous antiemetics and fluids, it's probably a reasonable time to check their electrolytes, although really it's only the severe cases that have clinically significant derangement. And then we have the option of intravenous antiemetics, fluids, and then in this group another time to just stop and think, is this someone who might benefit from thiamine replacement? Some other things to consider is venous thromboembolism prophylaxis. And we generally just do this in women who are admitted because these women are generally dehydrated, and the observational data suggests an odds ratio of around 2 for DVT and PE in this subgroup of women. In those where reflux or dyspepsia symptoms are a large contributor, then either a ranitidine or even a PPI, they all have a safe profile in pregnancy and can be helpful as an adjunct. We're going to go through some of the particular treatments and just a few details, things that you may have heard are used or see commonly or in fact already prescribed. The first one's ginger. There's a few small studies that suggest it might help, and so it can be used as, you know, something that women are eating or ginger flavoured drinks. You can even get ginger as a tablet. I think it's worth considering or suggesting, and definitely some women like a more natural option as a starting point. I guess the only thing I'd say is that some women are far beyond a natural remedy when they come to the emergency department, so just make sure you've got, you know, a second option ready to deliver when they look at you and shake their head. Now, pyridoxine is another safe medication. It's vitamin B6. Used in a dose of, it's broadly described, but commonly 25 milligrams orally 3 times a day. Now, there is some conflicting data on how effective it is. It's certainly been found to be effective in combination with an antihistamine. There's been some positive and some negative observational trials when it's used in isolation. But again, a common agent used in the early stages of nausea and vomiting in pregnancy management. Now, when we go to the antihistamines, we have doxalamine, which has a reasonable evidence base, and it's usually given at a dose of 25 milligrams orally at night. And also promethazine, which we probably use more commonly in practice because it has several indications, and it's used at a similar dose at night. And the main problem with these ones being sedation, and hence their nighttime use as opposed to the day. A very common group of medications is the dopamine antagonists. Now, I guess the main drug used in this class is metoclopramide, and its dose is 10 to 20 milligrams 3 times a day, and that's really regardless of its route of administration. There is some, thought that it's more efficacious at the higher dose range. So that's worth noting for people who only ever use 10 milligrams at a time. And just remember that some of the important or common adverse effects, akathisia is a symptom that just refers to a internal sense of unease and agitation, and that's it's actually really common when you talk to people who've had metoclopramide. And then more importantly, the acute dystonia is far less common, but more clinically significant, and they can occur with these agents, as well as prochlorperazine that we'll go through in a moment. Prochlorperazine or Stemetil can be given either orally, intramuscularly, and even intravenously. And the dose, can vary from 5 to 10 milligrams. There's also a 12.5 milligram ampule that can be used for parenteral administration. Mentioned earlier, there's a rectal suppository available. That's 25 milligrams, and again, an excellent way to commence the treatment in women who aren't tolerating oral fluids. I want to spend a little bit of time talking about ondansetron. Ondansetron is a serotonin receptor antagonist, the 5-HT3 receptor, and it's given most commonly sublingually, but also intravenously at the dose you can see there. Now, the reason I want to talk about it a bit more is there's been some historic concern over its safety, and particularly regarding an potentially increased rate of fetal cardiac abnormalities and cleft palates. And the reason I bring this up is that increasingly in my clinical practice, I'm finding women know about these concerns and they're asking about these things directly. And really, it's our role to be experts in these areas and understanding the best information to give these people. Now, there have been multiple studies, and in truth, the vast majority support safety. And I thought what I would just present is a trial from right at the end of 2018. So it's probably the newest piece of research out presently regarding the safety of ondansetron. And this was essentially a retrospective look at a database of 1.8 million women who gave birth between the year 2000 and 2013. And it looked at the 90,000 or so women who filled a script for ondansetron within the first trimester. Now, they're able to find no increased rate of cardiac abnormality. You can see an odds ratio that did cross either side of 1, but was, the point estimate of that was just below 1. But they did find a slightly elevated risk of cleft palate. And to give that in words that most people can understand, they sort of worked out that would account for 3 extra cleft palates for every 10,000 women who had ondansetron in first trimester, once all the other confounding factors had been accounted for. And look, for these reasons, it is usually second line. Another reason it's second line is that it's often an expensive script not covered by the pharmaceutical benefit scheme. But certainly the article in JAMA in 2018 is worth knowing about, so that you can counsel women with the best available information. Corticosteroids are something that aren't used commonly in practice, and I thought I'd just talk briefly about when they might be used. They're really just reserved for refractory cases, and it's important just to realise that severe nausea and vomiting pregnancy, in some cases, these women will undergo a termination, particularly if maternal health or mental health is profoundly affected. And now, of course, I'm not suggesting that corticosteroids are used when that's all that's left to do, but it's just important to remember that these women can have severe symptoms, and at that point it's worth considering corticosteroids as an option. The evidence base for them is reasonably weak. There's been some small randomised trials with positive results, and there's a more established increased risk of cleft palate in these women. There are other adverse effects of corticosteroids, both acutely with effect on mood, blood sugar levels, as well as longer-term risks of infection on cessation of corticosteroids, of secondary adrenal insufficiency, and a host of other things. So really they are, I guess, certainly far less benign than the agents we've already discussed. Now, the options for treatment, there's been no universally agreed upon prescription for corticosteroids for nausea and vomiting in pregnancy, but one option is to give women 100 milligrams of hydrocortisone twice daily, and when they can tolerate oral tablets, to start them on 50 milligrams of prednisolone, weaning down to the lowest effective dose. Some more practical information that you're going to use more commonly is just thinking about which women might need to come into hospital. And I think, first of all, it can be simplified as women with severe dehydration, acute kidney injury, or electrolyte disturbance. I want to take this point just to remind people that if someone is hypokalemic, just check their ECG. It's not uncommon to have prolongation of the QT interval, which, as we know, can lead to ventricular arrhythmias such as torsade de pointes, and it can be exacerbated then by some of the antiemetic medications we prescribe, such as ondansetron, such as metoclopramide and prochlorperazine, and even the antihistamines. So it really is a time to just be a little bit careful before we get gung-ho with our prescriptions. Other indications for admission include severe nausea and vomiting in pregnancy with just an ongoing inability to tolerate anything orally. If there's an alternate cause that has contributed to the patient's need for inpatient treatment, this might be pancreatitis, gallstone disease, complicated urinary tract disease, and other women who might need the establishment of either a nasogastric or nasojejunal feed or even total parenteral nutrition. Now, thiamine is something we think about a lot in our alcoholic patients. Remember that thiamine depletion occurs in malnutrition, not actually due to the alcohol consumption in other patients we see. It really is just, the lack of oral intake that commonly occurs in these patients that make us associate it with thiamine deficiency. But the women who have prolonged nausea and vomiting, and particularly those with pre-pregnancy malnutrition, really are at more risk. It's important to know this is very rare, and just remember that if you suspect acute thiamine deficiency or a Wernicke-Korsakoff syndrome, the dose of thiamine is far higher, 300 to 500 milligrams 3 times a day intravenously, versus the prophylactic or supplementary dose of 100 milligrams orally for women you just think are at risk of developing thiamine deficiency if their nausea and vomiting is to be prolonged. So that concludes the summary on nausea and vomiting in pregnancy. If you're prepping for exams and want more free practice, jump onto freeobstetricexam.com. And if you'd like a deeper, structured approach to learning obstetrics, the kind that actually sticks, check out theobstetriccourse.com anytime.